Good morning, everyone. Myself Nitin Sharma, roll number 69.
And myself, Yogendra Sharma, roll number 118.
Today, we are going to represent topic number 112, which is lung volumes and capacities. After this topic, we will able to answer what are lung volumes, lung capacities, and how we measure the lung volumes. So let's begin. First of all, what do we mean by lung volume? Lung volume are also known as respiratory volumes. Lung volume refers to the volume of gas in the lungs at a given time during the respiratory cycle. So there are four lung volumes. First is tidal volume.
Tidal volume is the amount of air that can be inhaled or exhaled during one respiratory cycle. This depicts the function of the respiratory centers, respiratory muscles, and the mechanics of the lung and chest wall. The normal adult value is 10% of vital capacity, approximately 300 to 500 ml, 6 to 8 ml by kilogram, but can increase up to 50% of vital capacity on exercise. Inspiratory reserve volume.
Inspiratory reserve volume. It is the amount of air that can be forcefully inhaled after a normal tidal volume. Inspiratory reserve volume is usually kept in reserve, but is used during deep breathing. The normal adult value is 1900 to 3300 ml. Third volume is the expiratory reserve volume.
It is the volume of air that can be exhaled forcibly after exhalation of normal tidal volume. The normal adult value is 700 to 1200 ml. ERV is reduced with obesity, ascites, or after upper abdominal surgery. Residual volume.
Residual volume is our last volume. It is the volume of air remaining in the lungs after maximum exhalation. Normal adult value is between 1200 ml to 1300 ml or 20 to 25 ml per kg. It is indirectly measured from summation of FRC, which is functional residual capacity, and ERV, expiratory reserve volume, and cannot be measured by spirometry.
In obstructive lung diseases with features of incomplete emptying of the lungs and air trapping, RV may be significantly high. The RV can also be expressed as a percentage of total lung capacity, and values in excess of 140% significantly increase the risk of barotrauma, pneumothorax infection, and reduced venous return due to high intrathoracic pressures, as noticed in patients with high RV who also require surgery and mechanical ventilation, thus needs high perioperative inflation pressures. This was the clinical aspect of the lung volumes.
So this is the graph of lung volumes and lung capacities. From here, you can easily understand the volumes and capacities. Now, this is the summary of lung volumes. Tidal volume. The average value of male is 500 ml and in female is 500 ml also. Inspiratory reserve volume. Average value in male is 3100 ml and in females is 1900 ml. Expiratory reserve volume. Value in male is 1200 ml and in female is 700 ml. Residual volume. Adult male average value is 1200 ml and in females are 1100 ml.
So now we're going to the next topic, that is the lung capacities. So lung capacities are of, again, 5 types. First is inspiratory capacity. It is a maximum volume of air that can be inhaled following a resting state. It is calculated from the sum of inspiratory reserve volume and tidal volume. So basically it's inspiratory capacity. So it's going to be the summation of inspiratory reserve volume and tidal volume. Next is total lung capacity.
Total lung capacity. It is a maximum volume of air the lungs can accommodate or sum of all volume compartments or volume of air in lungs after maximum inspiration. These are different definitions. Now, the normal value of TLC is 6000 ml. TLC is calculated by summation of four primary lung volumes, which are tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. TLC may be increased in patients with obstructive defects, which are emphysema, or may be decreased in patients with restrictive abnormalities, which include chest wall abnormalities and kyphoscoliosis, which we studied in previous slide, which was scoliosis. In COPD, COPD stands for chronic obstructive pulmonary disease. FRC is up to 80% of TLC.
So now this was the summary of all the respiratory volumes and capacities for males and females. So total lung capacity, TLC for the that is 6000 ml, and this is basically for males, and 4200 ml for females. Vital capacity is 4800 ml for males and 3100 ml for females. Inspiratory capacity is 3600 ml for males and 2400 for female. Functional residual capacity 2400 ml for males and 1800 ml for females. So this was a graph that can be shown, and this graph shows all the lung volumes and capacities.
Now we have completed lung volume and capacities, in which we studied about various definitions and graphs of lung volumes and capacities. By graph, we can easily understand the lung volume and capacities. If a patient have less lung volumes, it can be increased by yoga, or swimmers have high lung volumes. Now we are going to study about how we measure different lung volumes. Measurement of lung volumes are important for a correct physiological diagnosis. By if the lung volumes are high or low, we will be easy to diagnose the patient. However, its role in the assessment of disease severity, functional disability, the course of disease, and response to treatment remains controversial. Measurement can be done using spirometry, body plethysmography, nitrogen washout, and helium dilution. One by one, we are going to discuss about these techniques. First of all, we are going to discuss about body plethysmography.
Plethysmography is derived from Greek word meaning enlargement. Body plethysmography primarily measures FRC using Boyle's law. It is particularly appropriate for patients who have air spaces within the lung and that do not communicate with the bronchial tree. The person is seated comfortably in an airtight box. Starting lung volumes can be obtained either by measuring the changes in pressure in a constant volume box or volume in a constant pressure box, in which changes in pressure and volume can be measured accurately. Now, the next measurement for the lung volumes is nitrogen washout.
This technique is based on washing out the nitrogen from the lungs, while the patient breathes 100% O2 using dilution properties of gases. The patient breathes 100% oxygen and all the nitrogen in the lungs is washed out. Exhaled volume and the nitrogen concentration in that volume are measured. Difference between nitrogen volume at the initial concentration and the final exhaled concentration allows a calculation of intrathoracic volume, usually which is FRC. FRC is functional residual capacity. Now, helium dilution.
The method for measuring lung volumes is based on the equilibration of gases in the lung with a known volume of gas containing helium. This technique involves the subject being connected to a spirometer filled with 10% helium and oxygen. After the subject rebreathes the helium-oxygen mixture and equilibrates with the spirometer, the helium concentration in the lungs will become the same as in the spirometer. From the conservation of mass principle, we can write that C1 into V1 is equal to C2, V1 plus V2, where C1 equals the initial concentration of helium in the spirometer, V1 equals the initial volume of helium-oxygen mixture in the spirometer, C2 equals helium concentration after equilibration, V2 equals unknown volume in the lungs. V2 can then be further calculated by the following formula, that is V2 is equal to V1 into C1 minus C2 upon C2. If the test begins at the end of a normal tidal volume, that is the end of expiration, the volume of air remaining in the lungs represents FRC. If the test begins at the end of an FVC, that is forced vital capacity, then the test will measure residual volume. Similarly, if the test starts after maximal inspiration, then V2 would equal total lung capacity.
So thank you everyone, especially our HOD Sanjeev sir and Department of Physiology to give us the chance to share the presentation. Thank you all.
Myself Pushpinder Sharma, roll number 80. Today I am presenting part 1 of topic number 113, lung volumes and capacities. The topics which are covered in these presentations are determinant of air resistance, peak expiratory flow rate and closing volume. Airway resistance. When we breathe, the airflow causes resistance to air moving in the airway. In healthy individuals, airway resistance is about 1 to 3 cm H2O per liter per second. There are four determinants of airway resistance: diameter of airway, tone of bronchial smooth muscle, lung volume, gas density and viscosity. Diameter of the airway. It is the most important factor affecting the airway resistance. As more the diameter of the airway, less the resistance offered by the airway, more is the gas flow. The change in diameter of airway is achieved by contraction and relaxation of smooth muscle of the bronchi and bronchioles, which is under the sympathetic and parasympathetic control. Second, tone of bronchial smooth muscle. Sympathetic control. It releases the epinephrine and non-epinephrine into blood by adrenal gland, which stimulate the beta-adrenergic receptor, which dilate the bronchial tree, led to increase in diameter, thus leading to less airway resistance. When we talk about the parasympathetic control, parasympathetic fiber derived from vagus nerve penetrate lung parenchyma, which releases the acetylcholine. Moderate constriction of bronchiole led to decrease in diameter, thus increasing the airway resistance. Third, lung volume. Diameter of the airway is directly related with the lung volume. Bronchi and small airway are embedded in lung tissue, therefore, airway diameter increases with increase in lung volume, thus airway resistance decreases with inspiration and increases with expiration. When we look into this graph, it shows the relation between the lung volume and the airway resistance. As the lung volume increases, the airway resistance goes down, which ultimately shows that lung volume is inversely proportional to the airway resistance. When we see the site of the airway resistance, the segmental bronchi offer a great resistance. As these are very less in number, they they offer a greater amount of air resistance to the air. When we look into the conducting airways, they are very large in number, therefore their surface area is also greater in number, and they offer very less resistance to the air. When we look into the respiratory airways, the main driving force in this area is diffusion. Therefore, the amount of the air resistance is very less in number. And the fourth point, gas density and viscosity. Increase in gas density as occur in deep sea diving increases gas viscosity. Air density increases because of increased barometric pressure. Therefore, we use oxygen helium gas mixture as it has low density during deep sea diving. Thank you.
This is Sukrit Sharma, rule number 103, and I would like to continue with the topic 113 with peak expiratory flow rate and closing volumes. Peak expiratory flow rate. The maximum flow rate that is attained during a forceful expiratory efforts is called the peak expiratory flow rate. A person can quickly reaches a maximum expiratory airflow of more than 400 liters per minute, regardless of how much additional expiratory efforts. The expiratory flow attained is due to the pressure applied to the outside of alveoli and the air passageway caused by compression of this chest cage. As you can see in this diagram, the terminal part of the air passageway, the alveoli and the bronchioles. The effect of increased pressure applied to the outside of alveoli and the air passage caused by compression is that The pressure forces air from the alveoli towards the bronchioles, but it also tends to collapse the bronchioles at the same time. The effect of lung volume and maximum expiratory airflow. इस स्लाइड में हम देख सकते हैं कि जब हम एक्सपायर कर रहे हैं फोर्सफुली फॉर द फर्स्ट सेकेंड द पीक एक्सपायरेटरी फ्लो रेट rises exponentially high at a level of 400 liters per minute, and after 1 second it decreases constantly. When we expire with maximum efforts, the maximum airflow which we get is the maximum expiratory flow. In various conditions like in obstructive diseases and restrictive diseases of the lungs, this graphs varies exponentially, and there are various effects on this graph. Like when we talk about the obstructive diseases and the restrictive diseases, first for the obstructive diseases. In diseases with the airway obstruction, it is usually much more difficult to expire than to inspire because the closing tendency of the airway is greatly increased by the extra positive pressure required in the chest to cause expiration. By contrast, the extra negative pleural pressure that occurs during inspiration actually pulls the airway open at the same time that it expands the alveoli. Therefore, air tends to enter the lungs easily but then becomes trapped in the lungs. Over a period of months and time, you can see that the total lung capacity of the lungs increases and also the residual volume. In restrictive diseases like the constricted lungs, the, to- to- the total lung capacity is reduced and reserved volume is also reduced. As you can see, the reserve volume is reduced and the total lung capacity has also reduced. Furthermore, the lungs cannot expand to a normal maximum volume even with the greatest possible expiratory efforts. The maximal expiratory flow cannot rise equal to the normal curves. Constricted lungs diseases like fibrotic lungs such as tuberculosis, silicosis, the constriction of the chest cage such as kyphosis, scoliosis, and fibrotic biliosis. In restrictive diseases, the chest cage is compressed. We are not allowed to expand our chest fully, therefore the total lung capacity decreases, and this is also the cause to in decrease in the peak expiratory flow rate. As you can see, the curves are decreased in both obstructive and the restrictive cases. There is a note that we should always remember that lung volumes become smaller, the maximal expiratory flow rate also becomes less. The main reason for this formula is that in the enlarged lungs, the bronchi and the bronchioles are held open partially by the weight of elastic pull on the outside by the lungs structural elements. However, the lungs become smaller. These structures are relaxed so that the bronchi and bronchioles are collapsed more easily by external chest pressure, thus progressively reducing the maximum expiratory flow rate. Continuing with the topic, the closing volume. The closing volumes refer to the lung volumes that coincides with the beginning of the airway closure in the dependent part of lungs during expiration. In normal healthy individual, the closing volume is usually less than the forced respiratory capacity and more than the residual volume. Closing volume से हम समझते हैं कि वो volume जब when we are expiring forcefully, at that volume where the first airway starts to close, we regard that volume as the closing volume. जब हम expire कर रहे होते हैं और जब we attain the point where the first airway starts to close, that point is exactly known as the point for the closing volume. And at that point, the amount of air which we have expired will refer to as the closing volume. It is generally more than the residual volume and less than the forced respiratory capacity. When we talk, the first airway generally closes at the base of the lung because due to the lung weight at the base, the airways are usually compressed first at usually before at the apex of the lung. By that, I would like to thank you and